controversial. Okay. Oh, I don't know when the meeting starts. It didn't come up on there until that red line is done. All right, Dr. Malone, April the 14th now. Here in downtown Pensacola, say we. Michelle works in one part of the office, I work in the other part of the office, and I'm here. We have 2 people here, no more than 2 people here at a time, and the rest of the office is spread out around Pensacola and the surrounding area, and we work remotely. This is the 5th week we're working remotely. Fortunately, for our sake, the firm has not missed a beat. We signed up 2 or 3 clients today, 3 clients today, new clients. And we're still able to service those people with their the new client meetings via the Zoom or Facebook, or sometimes by the phone if they choose to do that way. We can email them the documents through different document services that allow them to sign very easily on their phone. So that's fortunate. What's unfortunate is we're still dealing with this in the 5th week. And I'm not sure there is a reasonable end in sight until it's going to work, until we have some testing, widespread testing, or some medication that is proven to be effective against the virus. What I'm concerned about is we pick an arbitrary date to come back into the work environment like everybody else is going to try to do. And somebody shows up here, either a client or a vendor, or it only takes one person that is a non-symptomatic or asymptomatic carrier of the virus, and then the whole office has it, and then everybody in our families have it, and then if somebody goes to church or somewhere, then the whole church has it. Like Governor Cuomo said, it started from 1 or 2 people that went to a religious activity where hundreds of people were accumulated, and those 2 people spread it amongst those hundreds of people, and then it got into New York City. So now he wasn't at the time, though, thinking about the asymptomatic carriers who probably also were carrying the disease in New York City and didn't know they had it, right? And because nobody knows, there's only been 1 million tests, right? There's 300 million people in the country, or 2 million tests, and there's 300 million people in the country. I guess 90 million are school age. So there's 200 million that are not school age that are in the country that are potentially asymptomatic carriers, some of them. Until we have a test that's able to isolate at least a percentage of your population that's asymptomatic carriers, we're just shooting in the dark on who's got it and who doesn't, and whether we should open or not, and whether we should go to big functions or not. And I'm not sure it makes sense to open us back up. But anyway, they're not here to listen to me ramble about that. They're really here to hear a medical professional like yourself, who's a board-certified internal medicine doctor, to talk about what's developed recently over the last 24 hours that relates to this virus. What information can you tell us that we can use to help us and families?
So I'll start with where we had left off yesterday, Joe. We had mentioned about the potential on how we were doing in the state, and I'll share this link here. This is the state dashboard. And I had said, hey, are we starting to flatten out or not? And if you look at the bottom left-hand corner, that's the new cases per day. Those gold bars. So the new cases per day, per day are certainly, they're plateauing, if not going down. That's not to say that we have a handle on this thing, as you just mentioned, but that's certainly a good sign, the new cases per day. Now, that said, there's still people sick and in hospitals. There's still deaths that are occurring in our state. So that right there is the one graph that I had mentioned last night. I said I was going to have that ready to go today. It's a little difficult to get the whole link in there on the fly. So if you wanted to drive around in here and look at where we're at just as a county, I'll get this zoomed in here. So Escambia County, as of this afternoon, has 247 cases total. And if you look at the testing, that's out of, oops, that's Santa Rosa, sorry. So Escambia County had 3,584 tests total, or actually 38 tests total with 247 positives. And that's a rate of 6.4% positivity, which we've been mentioning every day. So this link's out there and it's on the county website. So I encourage people to go check it out if you're interested in more information there. But I guess the main thing I want to draw people's attention to is, you know, in the county of, in our area, are we on this downward trend right now, or at least a plateau, which would be hopeful that maybe we're not necessarily fully containing this thing, but we're living with it and managing it the best we can right now without having the testing, as Joe had referred to, or even treatment. You know, antiviral treatment or vaccinations. So that's there. The other information that came out of the county this afternoon is hospitalizations are 21 locally. Again, that's over the course of this entire pandemic. So I guess 5+ weeks, and 4 deaths now in Escambia County, with 1 new one reported today. And the Long-Term Care Facility Association has 43 linked cases, and that's a combination of the patients and or visitors and or staff members. No further identification of the facility or the breakdown as far as the different demographic within that 43 as far as patients or workers or whatnot. So that information is still there. Any questions on that or any other points at all, Joe?
No, have you looked at, I know you probably haven't looked at this, but I would be curious to know, since we're a border community with Baldwin County, Alabama, Mobile County, Alabama, Escambia County, Alabama to the north. I would be curious to know what those counties look like as far as their peak is concerned and whether they're on the downturn or not. I'm not sure how sophisticated some of those counties may be data-wise, but I would think Mobile and Baldwin County would have some pretty good data out there. Have you looked at that?
I've looked at it on a state level at least, and it looks like they're calling the peak for the state of Alabama to be around April 21st. And that being said, Mobile County has got one of the highest levels in the state from the information I had on my end. I can get a more accurate, go ahead.
How many cases do they have in Mobile County?
I don't want to hazard a guess, but every news flash I see, it seems like they're right toward the top of the state as far as counties are concerned. I'll have to see if I can pull that up. If not, I can get that up for us first thing tomorrow, so we can look at that and analyze it as if
Baldwin County is pretty much, you know, right across.
Yeah, it's here.
Right across the way here. So
yeah, so I'll ever getting that pulled up so we can look at that tomorrow. Tomorrow when we have the outset there, so that link is on there. I imagine it's probably just as difficult to get into this presentation on the fly, but we'll get that for sure. And that's kind of what I've been looking at when we look at just the states that we fall in line with as far as the peaks. And I'd like to think that, you know, we're going to peak, you know, sometime this week, which is what they're, you know, saying Alabama and Mississippi and Louisiana are going to do. I mean, we're closer to those than we are to South Florida. And South Florida, the last peak was the first week of May. So I guess if selfishly, I'd like our county to fall into that group of states as opposed to South Florida. But we'll get that pulled up
Evan,
tomorrow.
From the graph you just showed me for Florida, it looks like we already peaked. We peaked to early April. And we're plateauing now, and then we're going. We hadn't started going down yet. Is that what you're saying? We hadn't really.
Yeah, it's not gone down, and their estimation is that there are people out there much smarter than I am, and they're not medical doctors. They're like statisticians and actuarials, I'm sure, that are still saying that on a demographic basis they're still expecting this to go up. I don't know on what basis, but that's the information that's out there. It's completely not medical, it's statisticians. So I guess it's trying to analyze their data and apply a medical spin to it. But yeah, they're still calling it to be at the end of the month or the very first part of May as far as the peak for the entire state.
Okay.
So,
all right.
We'll see how
so what else do you have for us today? Any interesting tidbits of medical information?
Yeah, and so you had mentioned just now, I guess, in your introduction there, there's got to be a better way to live with this, to anticipate it, to test for it, things like that. And so, as it turns out, there's a couple of different groups that are starting the idea of testing wastewater sites. They're
Hmm.
learning that the virus is shed in our sewage, basically. And so there has been a couple of groups that have found out, not this actual paper I pulled up here, we'll get to that, but it's kind of like a story within a story. But there's part of Massachusetts that had a higher concentration of infections around a water treatment facility. And so now Harvard, MIT, and Brigham and Women's is involved in a study there to try and analyze that. And I guess they basically said that they're not surprised. And then there's some other public health commissions that are finding some associations with wastewater having the virus in it. And it's not to say that you're going to catch it from the wastewater necessarily, but is there a way that you can monitor the wastewater as a barometer for the huge community that feeds a wastewater facility, and to do it in real time? And so this gentleman here has paper-based technology that he rolled out really to underserved and like really far off areas, like parts of the world where there is no hospital, there's no
What do they
electricity.
mean paper-based device? What is, like have like a
This thing is it's kind of like the closest thing I can describe is if you've ever seen like a urinalysis dipstick at a doctor's
yes,
office.
yes.
Yeah, so it's kind of like that, and it's flat. It's easily portable. You apply the water to it, and then you fold it up like this origami little like it's got pre-made folds in it, and every time you fold it, the sampled water rolls on top of like the reagent, then rolls on top of this other medium that helps it to replicate, and then it rolls on top of the positive or negative, like a pregnancy test, I guess.
Wait a
And
minute.
so
If they can do that, why can't we put it in our own toilet and figure out if we have it?
well, and that's kind of what he's hoping to do. I mean, he wants to develop this, and so he says that he's about a year out from developing it,
A
but
year.
he's been doing it already with malaria and polio and HIV, and this is not new. But his application to COVID is new, and it's real interesting read. I encourage people to check it out. And he basically says that instead of getting a sample and having it run on a PCR, the genetic test, which is what we're waiting days for our nasal swabs. He says he can get this thing done within minutes, and you don't need to be trained to do it. So they could have personnel like wastewater plants. They don't have to have a new scientist there that could monitor this and say, hey, we're starting to see a bloom here because this is showing up in the community before people are symptomatic. Time to buckle down, time to pull out whatever treatments we have available to try and cut this thing off at the pass. So testing wastewater, I think, is probably something that on a communal basis is going to happen, at least based on this, or it'd be one way we could do it before you get to the
So
individual testing when you wake up every morning.
that means the virus is excreted in urine and bowel movements.
Stool. Yeah, stool. Yeah, and so there's no links at all as far as it being communicable that way. They're just finding that there is some levels of virus in our waste, and so it's something that it's not to say that you're going in raw sewage. These are water treatment facilities that they're able to pick it up as far as being. I guess they can sense it with the paper mechanism that he's got that he wants to roll out. So he wants to get that going, and it sounds like his
Which one is
paper.
he?
Probably the lead. Probably the lead guy up there is my guess.
And this is not
he's
a
got
Chinese
a paper. No, no,
Oh.
and they've been doing it. They've been doing it in other parts of the world. So if you look at this, look at these pathogens that he's malaria, rotavirus, Zika virus, HPV, HIV,
Wow.
E. coli. So this is not new. He's been doing it. He wants to get it rolled out to the use on COVID, and this coupled with the associations that we have at least in the States here, where the situation where the MIT and Harvard are saying, hey, yeah, like we're finding an association and it's just around this one water treatment plant. That's not because the water treatment plant caused it. It's because there's a hotspot around that water treatment plant, and the water treatment plant is now another way of measuring. Oh, hey, we found a hotspot.
Scroll
So,
down.
anyhow,
See where this guy is located. There he is. China.
Yeah,
So,
and he's been rolling.
I mean, I'm sure this guy's on the up and up, but I'm quite skeptical of the Chinese folks right now.
Okay.
Given the, here's what bothers me about China. Tell me where I'm wrong. First of all, they're reporting that they only had like 80,000 deaths, I think is what they said. Is that wrong or right?
I thought it was like 3,300 or something.
Was it even lower than that? Whatever the number was, I just remember thinking to myself, that seems really low, because that's the first country to have this, and they didn't even acknowledge it. And they punished the people that did acknowledge it for weeks, if not months. So here we are trying to be, we had a little bit of a delay at first, but then we got on the stick, right? Pretty quickly. We had a month or so, or a month and a half delay, but we got on the stick quickly. We started social distancing, and we still have 25,000 deaths as of today, right?
Yep.
So how could the place that didn't even know it existed for 2 months not have more deaths than us?
Yeah, I agree. So they had 8,300 cases that were published, and then 3,300
Bullshit.
deaths.
Excuse me, but bull. There's no way that's right. I don't know if YouTube has a censor, but they need to. That is crazy talk. Okay, so that's my issue with the Chinese government, and I shouldn't say Chinese people. Chinese government.
Yeah.
The Chinese government seems to have underreported this, both in cases and deaths. And it sounds like to me what they're doing is, the Chinese government again, is, oh, well, they died from pneumonia. Huh? How do we know it's COVID related? We don't know for sure. There's probably hundreds of thousands of people that died from pneumonia and organ failure and whatever else before they got all their stuff together, and they just didn't say, well, let's go back and capture those. They probably did die from COVID. They're just like, oh, we'll just let it sort of be around 8,000. That's a good number.
Well, so to defend the paper I put up there, it is sponsored by the UK and Natural Environmental Research Council and the Royal Academy of Engineering. So
how about this question? How about all the stuff that he cites, other tests that he cites for Zika and the other stuff? I wonder if those are real devices that are actually being used.
Yeah, they are. No, they are. They're being used in like third world countries like Uganda, and it's for like the malaria to anticipate when malaria is going to have an outbreak in these communities that basically malaria is endemic. Well,
I'm aggravated by the Chinese government's underreporting of these things, and it's really, I mean, this is a life and death issue, and they're trying to figure out the best way to look better to their people or to make it look like they're more in control. And then they turn around and blamed us for this. I mean, it's just like, are you kidding me? You got to be kidding me. So, all right, what else do you have?
Okay, so we touched on this, and I guess it was.
I want to dipstick for my own toilet, by the way, because I'd like to be able to test my own toilet, and I like everybody in my office to be able to test their own toilet, because until we're able to test ourselves, we're all going to be walking around wondering if the other person has it. So I'm not sure. Test the wastewater that's located, wherever the wastewater, at this, for me on the beach in one of those tanks. But that's going to narrow it down to what, everybody that lives on the beach or went to the bathroom on the beach. I really need to know if the people in my office are going to have it.
Well, and I think that, you know, it's within reason. That's what these people are trying to test. They're trying to innovate and say, how can we detect this thing on the fly without having to do the swab your, you know, the back of your throat and wait 6 days,
Well,
or even
I
wait
applaud that.
wait a day. So we'll
I
see.
hope that happens.
There may be some sort of paper testing that can be done. You
I
know,
was just
every
thinking I
day.
was going to have to stick a Q-tip up my nose until I passed out and then rub it on a piece of paper and do that. I thought that's what we're going to end up doing in our house, right? And I'm fine with that. But if you want me to stick it in the toilet, I can do that too. I just want to have a test. Either way,
Yep.
toilet, nose, whatever. It all sounds unpleasant, but
Yep.
we got to do what we got to do under these circumstances. What else
Yep.
did you find for us?
I was going to pull up. We had talked about this last week, I think. And so here's your first domestic study on it, and it has to do with obesity. The last sentence right there. Unfortunately, this is a New York City study. So they looked at the hospitals and admissions there. Unfortunately, obesity in people under the age of 60 is a newly identified risk factor, which may contribute to increased morbidity rates experienced in the US. And so the cutoff was BMI over 30. So they found that they only looked at people under 60, because people over 60, we know, like, they're at risk. It doesn't matter obesity or not. They're trying to say, you know, that if you're under 60, you can't ignore this as a risk factor. So they found that your risk of getting it was, if you had obesity, your risk of getting it. Let me scroll over to the next page.
And define obesity again for people, how they define it. BMI of what?
So they had it greater than 30, as far as their what they defined as being overweight enough in here to make a big difference. And so right here, patients aged less than 60, BMI between 30 and 34 were twice as likely of being admitted to the ICU. So
Damn.
if you're
Those are big
not,
numbers.
yeah, so it's a significant association. And then if you had a BMI greater than 35, and then your risk of being admitted to the ICU was 2.2. 2.2 and then 3.6 to go to the ICU. So obesity is now the American risk factor, basically. So they looked back and they said that before this they had South Korean, Chinese, and Italian models, and they looked at risk factors there, and they knew that smoking and pollution and an aging population, those are the things you heard coming out of South Korea, China, and Italy, respectively, right? Why was Italy's death rate so bad? And they said, oh, well, there's multi-generational homes, and they're much older people that were dying. So we knew that, well, send it to the United States and we'll tell you that obesity is a risk factor now too. So that's something that
Are more people obese here
recently.
than Italy?
I think that's what their assumption was, and I think that's based upon the data that they had available to them. I don't think they didn't do a direct comparison in this paper here, as far as, you know, were the deaths here more obese than the Italian deaths. So they're looking straight up at Americans versus Americans. When they come to the ER door, are they going home and told to huddle up for 2 weeks, or are they getting admitted? And then they looked at their weights, and then they said after they get admitted, are they going to the ICU because they're getting even more sick? And then they're also looking at their weights, but they only looked at people under the age of 60 for this. So
Right. Thing for us to know. I don't know how that helps people that are already obese, other than stay away from people that, I mean, you need to be considering yourself high risk is basically, if you're under 60 and your BMI, I can't remember the percentage, what that means in pounds. But if your BMI is 30 or more, then you're high risk, even if you're 26 years old, basically.
Yeah. And so I'll pull up a BMI calculator real quick so I don't misspeak. But so BMI for 5'7" male, BMI of 30 would be, let's see here. BMI of 30 for 5'7", I think that's over 200 pounds. So let's see here, 200 pounds for 5'7" is, you're falling in that 30 to 35 range.
Okay.
So if you're 5'9",
5'9".
Okay. So as your weight goes up, as your height goes up, but you weigh 200 pounds, 5'9", 200 pounds, you're between the 20, you're 27.
All right.
So
if you're 5'9" and you weigh 220, yeah, you're probably gonna be pushing that limit.
5'9", 220, a BMI as a male. Yeah, you're in that range. You're between 30 and 35.
Yeah, you have to. What I think what we're saying is, and I don't know what percent of the country is averaging out at higher BMI than 30. We have numbers for that. What percent of our population?
In their paper, their population under the age of 60 that had a BMI over 30 was like 36%.
Wow.
A third of the population.
Wow.
Yeah. So they said it was in line with that, and that's the numbers that they saw coming into the hospital. They were in line with, it was like between 36 and 40%. And so it was representative of the population. And then of those people that showed up, the ones that were obese had a much more difficult course, either being admitted or going right to the ICU, or both. So.
All right. What else do you have for us?
So then the last thing I had is e-medicine. So you started today by saying, hey, we're doing all these things electronically at the firm, right? Or doing all these Zoom conferences and all that. And we're doing it because we were put in a position that was survival. That's the way to maintain your business and the services that are provided to your clients. So telemedicine's been going on for a while before all this. However, this is the wrong time to do a study of telemedicine, like in the thick of it all. So what they did is there is a, let me get the link here, just a second. So there is
Don't you wish all your news had recognized journal articles as a basis?
Yeah.
I mean, it would be wonderful if everything we watched on TV had this kind of backup, It's like, I'm getting ready to tell you something, and I'm getting it from this. And you can go look at it yourself if you want to.
So here's the American College of Physicians, the Annals of Internal Medicine. So they did, so they did what they're calling a retrospective review of, it was limited. It was community hospitals, like in one integrated system. So think like locally, they basically just looked at patients that were part of the Ascension system, and they looked to see the utility of these electronic consultations where one doctor wanted a patient to see another doctor for whatever reason, like, hey, you need to go see your cardiologist. And some of these were done. It was between October of 2017 and November of 2018. So they've gone back and they've dug through all this to say, were these appropriate consults? Was it something that should have been done in person? Or was it appropriate to do it this way? Or was it an abuse of the system? Like all of a sudden, oh yeah, we can rip off like a bunch of e-consults all day long and bill for it. So let's just do a bunch of those. Right. So they looked at that to say, was it appropriate or not? And so they said, overall, 70% of the e-consults met all four of the criteria that they laid out to define the utility of it. So they weren't just abusing the system. And then they kind of broke it down a little bit further. But their idea of this is they wanted to come up with some metrics that they can use to assess the appropriateness moving forward, especially when we're in pandemics. So yeah, you have a pandemic that's saying, hey, you need to do an e-consult, but still there's certain times when, even though there's a pandemic going on, you probably need to be seen in person, depending on what the issue might be. So coming up with a rubric of sorts that will help drive the decision-making so that you say, yep, this one, it needs to be a one-on-one consult. This one can't be. And so it's a decision-making system to help everybody involved, the patient, the doctors and all that, but also billing is at the root of a lot of this stuff, unfortunately. And so there's going to be codes that are associated with electronic consults versus in-person consults versus consults that require, nursing intake and things like that. So this is starting to be measured. And I guess I've had discussions multiple times with people saying, I really think that the pandemic is going to change the way we do business. So if someone was in an industry of flying to Atlanta for one meeting and then flying home that night from Pensacola, and all of a sudden for the last 5 weeks, they've been doing it by Zoom, you'd have to think that maybe there's going to be more of an inclination to keep doing it by Zoom,
no doubt,
if it's working. So their idea with them doing with the study was, hey, we think that e-medicine is going to keep going forward, and this is just gas on the fire to try and keep that.
I had a client today that told me that they were going to attend one of their therapy sessions,
Yeah.
Via
Yep.
telephone.
Yep.
And
So
they
said
just started that this year, or this
Yep.
since it happened, and that he thought it was as effective as going in for their medical checks or whatever they do. He was a psychiatrist, I believe. And
yeah. They said that the overall rate, and I won't pull it back up, but the overall rate of attaining like a valuable consult this way, psychiatry was the highest, 92.6.
Okay, that makes sense.
And the lowest was dermatology. Because dermatology, it's a hands-on thing. It's not just the way it looks. It's a tactile study. So those are the situations where, if you want to follow up from a consult, from a dermatology consult with Zoom or whatever, then you can do that. But the initial consult probably is not the best for some fields, and so that's what they're trying to discern. But they did find that psychiatry is one of the ones where you can have a session with a psychiatrist or a mental health provider by e-consult and actually hit all their little criteria that they laid out right now. So it's I guess that there's some proof for the person you had spoken with.
Very cool.
So,
all right.
Yeah. So that's what I got.
What's going on the nursing home front? Because that that continues to be an issue. The Miami Herald sued for a release of the facilities, I think, in Broward County. And as part of that, the governor's office threatened to pull business from a law firm down in Miami if they filed that lawsuit on behalf of the Miami Herald. And so that law firm withdrew, and they found another law firm to file the public records lawsuit or petition. And so this is something that's happening all over our state, this thing about disclosure. I saw something in the paper yesterday or today that Mayor Robinson was in favor of disclosing the name of these facilities, and that wasn't happening yet. Where are we with that? Have you heard anything or know anything about where we are with disclosure?
I've heard the same exact thing you just said there, and they're saying it's protected health information, and they're treating it as if it's the HIPAA compliance matter and not a community or population health matter or concern.
Well, are they telling us where? Like, I remember some data when this first started. You were telling me there's one on Pensacola Beach, and there's one in Perdido Key, and there's one in Cantonment, and there's one in Santa Rosa County and Milton. Or how do they get that information, and why is that not a violation of some HIPAA regulation?
Well, I mean, the HIPAA, because it's not healthcare. So when you go to your home, you're not walking into a facility that's providing a service. You're walking into your home,
okay,
or wherever you live.
But even if I request information, which we do all the time in medical cases, or even in car wreck cases, I can ask them to don't give me any identifiable information. Just give me all of the data doesn't identify the patient. Like, if you go through a medical chart and you take out all the identifiable information about the patient's name, their address, their social security number, their date of birth, everything that would tie it back to that patient, and you just give me the diagnosis, how is that a violation of HIPAA if all the identifiable information is withdrawn from that? And that's all we're asking.
Yeah, I agree with you, and I think it's probably a tortured take on the violation that they don't want to undertake. I think they're really trying hard to say, yeah, it's a violation of public health information, or of protected health information. So that's
I would encourage
medical. Yeah.
Let me just do this. Let me encourage any family that's in Pensacola or the surrounding area that's having this issue. I would encourage you to look into this issue further. I think there's a need for somebody to file a local case for a public records request to one of these facilities that's refusing to identify these folks, especially to the patients. They could easily say we have 3 cases, we have 4 cases, we have 0 cases, without identifying a particular patient. And they do that all the time in facilities when there's some type of contagious disease. So I'm not sure why they shouldn't be doing that.
They do it at schools. Well, they do it at
Right.
schools, like when there's
Listen,
lights.
I get a note home if a kid's got chicken pox or a kid, and they won't tell me the name of the kid, okay? But our lice, that happens 4 times a year. Well, guess what? Same situation, much more serious subject, same situation. So I don't get it. And I would encourage anybody watching this video locally here to pursue this. And this needs to change. This behavior needs to change. So this is potentially endangering everybody else, not only in that facility, but outside the facility. So, I mean, the workers, what the heck, the workers, what about the workers in the facility? Are they not entitled to know that 8 people that they worked on that day have the coronavirus?
Or a vendor dropping off the food at the facility,
And a third of them potentially could be critical or in ICU according to this data. Let me tell you something. There's no excuse for this. So it sounds like there's some politics, some business interests, some, maybe somebody's got legitimate health privacy information that I haven't thought about or that you haven't considered, and I don't know, but all right. Appreciate your time today. Appreciate all the resources you cited. We're gonna put links to those in this video or below this video. We will see you tomorrow, the 15th of April, which used to be tax day, but it's not because of the virus. That's one good thing about the virus, I guess. We don't have tax day tomorrow. It's extended, I think, till June.
July
for now. Okay. So we will see you back tomorrow. You can find us on the web at zarzaurlaw.com. You can call us at 855-HIRE-JOE. We're still running full steam, representing mostly medical malpractice cases and car wreck victims. But we all handle all kinds of personal injury cases. Anyway, you can comment on this video if you want underneath the video. You can email info@zarzaurlaw.com if you have a specific question about the firm or these video or for Dr. Malone. And otherwise we'll see you tomorrow, hopefully with more encouraging information about the direction of this virus down. Y'all take care. Have a good evening. Thanks for watching.
Bye now.